Okay, I think we have a decent quorum. Thanks for joining us. This is going to be our last session of the spring series. I hope it's been enjoyable. I've certainly really enjoyed it myself. A reminder, as always, not to disclose any private health information during your case discussions, and the usual reminders about assistance, and the usual reminder about cardio. We do have a couple of things today. We're going to have a didactic presentation by Adam and Yasir Tarabichi. But instead of case presentations, what we've done in the past is used the remaining half of the session for some addressing of loose ends. And we do have a few questions that we're going to pose to our experts. They happen to be about type 1 diabetes and etiology of diabetes, et cetera. We'll get to that. I also had a couple of questions I wanted to throw out to get your opinions on as well. And these are our disclosure statements. I don't believe there's any changes from last time. And so today's session, which I'm really looking forward to from Yasir and Adam, deals with electronic health record systems and how they can help us address not only cardiovascular risks, but also social determinants of health. So Yasir, please take it away when you're ready.
So thanks for having me. It's a pleasure to talk to this group about the EHR and its role in cardiovascular risk assessment and management. These are the learning objectives. I should say, so I'm a physician informaticist at MetroHealth. I'm a pulmonary and critical care doc, and most of my time is spent dealing with the electronic health record and EHR data. So clinical decision support is something that I think about a lot. So learning objectives for this session, we're going to discuss the role of EHR systems in identifying and assessing and caring for patients at risk for cardiovascular disease. We're going to briefly define clinical decision support and spotlight some features of a well-designed CDF system. And then third point, describe the incorporation of social determinants of health into the EHR. So the question kind of that I posed at the outset here is, can you use an electronic health record to identify and or manage patients at increased cardiovascular risk? And if you think about the kind of data points that go into the EHR and the kind of systems that we have to leverage, there are a couple of potential options, and you may have seen or heard some of these through your journey into the electronic health record. We have risk-based patient registries. So identifying certain shared patient criteria, putting them in a list, which is then basically actively tracking certain conditions or questions that are relevant to that population. We have risk-driven clinical decision support prompts or interventions. So those are what we typically call kind of colloquially BPAs or best practice advisories, although those are very specific types of CDS systems, more of the pop-ups, more annoying than helpful potentially. We have individualized decision aids or patient decision aids, which assist in the aspects of patient education and shared decision making. And then we have kind of more recently these data self-service tools or self-service data query tools. And one that, at least for the Epic institutions, that should be familiar is Slicer Dicer. That photo that you see there is a dolly rendition of a doctor using technology to care for patients, and it's nightmare fuel. So, here's the thing about EHR data for those of us that live and breathe it, proceed with caution. So the promise is the EHR has rich contextual data about an individual's baseline health or life experiences, and that it's just ripe for model building with minimal output. All these publications about AI and EHR data and healthcare make it sound really easy, right? Make it sound like the data is pristine and perfect. And we all know that the reality is very different. The EHR, in effect, is a highly biased secondary data source with variable data quality and completion. And we know, just to kind of reflect a little bit on this, that data patterns and the presence of data reflect systemic bias. So that's a problem. So here's the kind of logic thought experiment for statin therapy for primary prevention. I pulled this straight out of UpToDate, and I kind of looked at it and said, well, how likely is it that an EHR is going to be able to guide you down this pathway in the right way? And what jumps to mind kind of right off the bat here is that if you start going down this and, for instance, evaluate the patient for a family history, well, we all know that family history fields in the EHR are notoriously incomplete and not inaccurate. Maybe on the right-hand side, you can figure out a way to calculate 10-year cardiovascular risk, thinking about how you can apply discrete data and EHR to flowcharts like this raises the concern that a lot of these pathways that are developed maybe aren't coming from a data availability or EHR based perspective first, right? And so there is a push to redefine clinical guidelines through the data that we have today to make more informed decisions. In our EHR, at least, we have an ASCVD risk calculator, which for those of you in Epic is kind of a dot phrase, if you will. You type it in, it'll calculate a risk score based on patient characteristics. And I'm just showing an example here. You can kind of go through it and think about what are the fields that I trust? What are the fields that might be problematic? How far back does the scoring system go? So for instance, looking at systolic blood pressure, which one are we using? Is it the last one? Is it an average? Right? Which lab test is this? Obviously that's configured on the back end, but this doesn't provide any clarity, right, as to how that math is happening, where that variable comes in from. And then things like race, for instance, they're not self-identified. Right? A lot of those are potentially biased and incomplete pieces that can significantly affect the calculation and the management decision as a result. So assuming it even works, is it even relevant in my population? This is a paper from Adam. I hope Adam's on if he wants to chime in. I should check to see if Adam's here. Oh, he is.
Yeah, sir, I can. So the challenge here, so what we did here was in a pretty humongous sample of people of about, I think we had maybe 200,000 patients here in Northeast Ohio. We looked at effectively that same calculator that Yasir was describing. But what we did is we re-estimated the risk using the observed risks by looking who actually had heart cardiovascular events in the EHR. And then we just, in this plot, we just stratified it according to an index of neighborhood socioeconomic position. And what you can see is that in the bottom right, and actually both of the bottom panes, you can see that it actually works pretty good. So the calculator is sort of like those risks are sort of right on the prediction line. But as you get toward the top of the figure, where you have folks who live in the most socioeconomically disadvantaged neighborhoods, what you can see is we drastically under predict risk, right? So it's like in the top left, if you see like that green dot. So those are people for whom the calculator in the EHR would have predicted that they had a 7.5 or 10% chance of having a hard cardiovascular event. But their observed risk was closer to 20%. So 20% of them actually had heart attacks and strokes. So they had threefold higher observed cardiovascular events than what was predicted. It's like, that's sort of like a disastrously bad, right? Like it sort of so for that subpopulation, it really sort of almost fully negates the purpose of the prediction tool.
Thank you. So then that might be more a reflection of the models that, the biased models that we use today, right? But minus the data quality, right, and the data provenance. Still an issue to consider. So putting all these data issues aside, how can we operationalize this? We talked a little bit about thinking about registries. So having a registry for statin intensification, it's not going to work, right? So a dashboard that tells you there are 10 patients that need a higher dose of a statin, it's not really at the right place at the right time. We'll talk a little bit about clinical decision support and shared decision aids. And then personal panel review, again, kind of a high level view, not really great for actionable insights at the point of care. Point 2 here, define clinical support and features of a well-designed CDS system. Broadly speaking, I borrowed this definition from the American Medical Informatics Association CDS working group. CDS is a process for enhancing health-related decisions and actions, empowering clinicians, patients, and other stakeholders by enhancing clinical decision-making and clinical processes, and improving the quality of healthcare services and patient outcomes. And this is a figure that's often repeated here, where provider plus computer is greater than provider alone. Another way to think about clinical decision support is it can reduce the cognitive burden of the provider to do the right thing. So it doesn't always necessarily have to improve the outcome if the outcome's the same, but if it makes it easier to get to that outcome, then so be it. These are some kind of rules that we go by in the CDS space. The 10 Commandments are classic. It's been a while. I don't know that they're necessarily need to be updated because they're great. So you want to be fast, anticipate needs, do it in real time, fit it snugly into the right place in the workflow. Whole things matter, i.e. usability. If it's a frustrating experience, people are not going to engage with it. This is another good one, number 5. Physicians resist stopping, which is an important one. So if somebody's ordering something and then you stop them, it's probably not going to change their behavior. Nudging people in a better direction is easier. The simpler the intervention, the better. Ask for information only if you need it. Seems rather obvious, but a lot of CDS feel that. And then the big ones are monitor, manage, and maintain. So get feedback. And then on the right-hand side, there's a couple of kind of distilled ideas from the original commandments showing how that actually does impact the effectiveness of CDS in reality. Here's the problem. We know this, right? Alert fatigue, workflow disruptions. And frankly speaking, clinical improvement per se with CDS is small to modest at best in a meta-analysis of controlled studies. And on the flip side, frankly, clinicians will accept complex solutions as long as they actually feel like they're useful. What happens when you add predictive modeling, sort of like the ASCVD score to the matter? Well, it gets more complicated, right? So you combine the misgivings of CDS with the vagueness of more advanced statistical methodology. And in general, on the plus side, right, clinicians or end users are generally interested in prediction-based CDS. They're naturally Bayesian in their thinking. They think about probabilities, but they still prefer processing mechanistic risk factors. So they want to know, for instance, in a risk score for stroke, that age makes sense. I mean, that's a logical one. So when there's an increase in that score, that makes sense to them, right? They struggle with statistical concepts, even basic things like sensitivity and more advanced things like discrimination or calibration. And as Adam showed, we are all generally worried about exacerbating racial disparities with more complicated models. And so a good example of CDS in the space is statin intensification. And this is a semi-recent article in 2020 that looked at the effect of a passive versus active choice intervention. So meaning interruptive alert versus a passive alert versus no alert for high-risk patients based on their risk score. And it's kind of unfortunate, but they found no difference in the main outcome of statin prescription or intensification. Another really good example to raise here is, or thinking about shared decision-making, is the statin choice by Victor Montori. This is an example of the screen that's presented to patients and providers, and it's supposed to engage clinicians and their patients in the actual discussion using a pictograph to say, well, here are the risks and benefits of a statin with your individualized risk. Again, understanding the problems with the risk calculators today. So here's the data about that. Several RCTs from his group showed improved knowledge, trust, and decreased decisional conflict with this tool, but uncertain no improvements in compliance and clinical outcomes, which is definitely disappointing. That first point's important. So it's nice to be able to engage patients and for them to have knowledge and understanding and less decisional conflict. But at the end of the day, clinicians are spending more time with patients using these tools and not actually changing the clinical outcome, which is the purported main goal or benefit. Trickling down through some of these other solutions here in the EHR, we have self-service tools. Slicer Dicer is the one that we use in our institution. There are many others. I think some of you may be sending data to Trinetics, for instance, and you're able to use Trinetics in a similar fashion. And I'm just showing you an example where I'm looking at my patients, the patients that have been seen by me, with an ASCVD risk score of 10% or higher, excluding patients, that's what the red box is, that have an allergy to statin or are on statins. And so then what I end up with this number here on the left-hand side, that 43, that's 43 patients who probably should be on a statin, are not allergic to statins, and require some kind of intervention. So I'll tell you my experience with this, generally speaking. We assume that these are failures, but when you go into the chart and actually start reading narratives, you'll discover that either patients didn't tolerate them, but they're not listed as allergies, or outright refused them. And this highlights one of the problems with the lack of discrete options in the electronic health record that can help guide this kind of querying. So an administrator would look at this and say, we need more standards. But the reality on the ground is we've tried. The third point here, describing the incorporation of social determinants of health into EHR systems. So I don't know if Adam, you want to talk a little bit about this. You may be closer to this than I am. It's up to you.
Sure, thanks, Yasir. So this has been evolving now for, I would say, roughly 10 years nationally. There was a task force nationally that worked with the Epic Corporation and some other stakeholders to determine which social determinants domains would be added to the electronic health record system and which specific screening tools would be used. So we conducted, I was on this little task force, we conducted for about a year, we conducted a review of everything that you could ask. And we boiled it down to this group of domains. Some of you might not be asking the digital connectivity question. That was one that I lobbied for, but couldn't get nationally, but I did manage to get the lovely informaticists at MetroHealth to add it to our system. And so effectively, the workflow here really depends on the institution. At Metro, a lot of folks answer these, ironically, for the digital connectivity one via MyChart. It's probably the vast majority of folks are push the questions prior to a visit. And so that's a selected group of patients and something to consider too. But we also have some places where we do it paper and pencil, and then we have some active outreach where some care coordinators will ask the questions. You want to move to the next slide, Rick? Or yes, sir. So we generally use one of these like screening brief intervention referral models at every place that does this. So as I said, the screening can occur in multiple settings. At one point, we actually did tens of thousands of these when everybody was getting their COVID vaccinations and vaccine clinic. And then the idea is that for some things, you can do a brief intervention right there. For others, it's more often that you need a referral. And then the trick here is this closed loop referral, where do we know if the community-based organization, say it's the Cleveland Food Bank, actually completed the referral that we gave somebody who said that they were food insecure and wanted food. And then in this last little area, we can sort out, well, what did that actually happen? And can we improve our process then based upon that? So what we've created then is a really nice sort of actionable improvement cycle. Next slide, please. So this paper by the group at MetroHealth that worked on the first batch of data. So they did this back in 2021 when I think we had maybe just under 100,000 persons gone through. They took a subset of where they knew exactly that everything was happening and that all the referral pathways were actually set up. And so I'm just going to tell you a little bit about the finding of their study, which is a little bit grim. Next slide, please. So so they took this pool in a very confined period of time because this was a group that they knew that everything that had happened should have happened properly. So it was about 10,000 patients. And what you can see is that out of the 10,000, a little more than half were screened, right? Completed the screening, right? So these are all people who we wanted to screen, but about a little over half of them were actually screened. And then of those who were screened, a little under 20%, looks like 17%, were actually food insecure. So they answered the food insecurity questions and then they had food insecurity. So that's like looks like 988 people. Then when we go to the next step, of those folks who didn't have food or who screened positive for food insecurity, some of them didn't want any help, right? About 100 of them, about 10% didn't actually want any help with security. And then, so for those people though, of those, only about half of them actually got the referral, right? So for whatever reason, the care team, the clinical information system, whatever happened, we don't know the exact gap here, but we know that after they consented to the referral, because we record that in the EHR, the referral only got placed for 42% of them. So that means like, of this total group, we only had, 350 or so referrals. And then what we do know is that the outside care provider here, it's a version of the Cleveland Food Bank, acknowledged the referral and said like, oh yeah, we'll get this person food 98% of the time. But then they were only able to confirm that the patient actually received food 27% of the time. So, out of the total, like a little under 100 received food. So this is so it's great. Like we got 100 people food who needed food. That's fantastic. On the other hand, there are all these steps along the way where these processes are in need of improvement. And what you can see is like, it's not any one place that we can target where we did especially bad. And in that last step, one of the things that we learned anecdotally is that like, well, probably way more of those people actually got food. It's just that the process that the food bank has for recording the data and acknowledging like, oh yes, this person, this person actually did come by and pick up food, or they were delivered food, or whatever the process was to get food. Like they just weren't very good at recording that had happened. So we think that way more got it, but we have no way to prove it because their data quality process just isn't very good. So you can see like there's some really awesome potential for these systems, but there's also a really long way to go. Like if the analogy here were something, if we took some sort of critical health event that somebody had and we only did screening half the time, and only half the time did we place the referral, and 75% of the time of the patients referred did we actually do anything, we would feel really bad, right? If it was some clinical thing, we would be like, this is crisis mode, we're totally failing. So it feels similarly bad here. On the other hand, we're just starting, so maybe we're going to have an opportunity to improve because of the data systems. I think with that, you can go to the next slide, and that's it. So there's this little statement from this very nice sort of review. The review is very good. It's super positive. It says that there generally is a good reason to continue to do this, but notably, one of their primary conclusions is that one of the best reasons to do these social needs screenings has little to do with the individual benefit that individual patients receive, like getting food, and has a lot more to do with sort of population health and policy, and sort of knowing like what component of the population actually has needs, being able to make predictions, and then being able to move larger resources. And instead of these one-on-one brief intervention referral, which can be effective sometimes, but that the sort of like bigger picture, I guess maybe more upstream or policy advocacy oriented outcomes can be far more powerful. And with that, I think it is question time.
Okay. Thank you, Adam, and thanks, Yasir, for a great presentation. Adam, I just had a question for you, going back several slides near the beginning, and that deals with the risk you found. You found the pooled cohort equations were not really good at predicting cardiovascular risk in our kind of Northeast Ohio population. They underestimated risk. What is driving the excess risk? Is it blood pressure? Is it stress? Is it what do you think it is?
This is a really, really tough question. Our team has been scrambling to get funding to do more projects to really pin down and answer that question, because like the causal linkage is very, very hard to determine, right? So like another way of stating the finding of that work is that when we looked like at looking just at the clinical indicators of the pooled cohort equation, if we use that for our region, we find that it only explains 8% of the variation in cardiovascular events, right? 8%, like that's not a lot. Like, and so that includes smoking, only explains 8%. But when we include the single indicator of neighborhood of where a person lives, it's 38%, right? So it's like this drastic, right? It's like almost a 4-fold increase in our ability to predict who's going to have an event just based upon that single indicator. And so I think, you mentioned stress. So I think the description I would give is it's more of an accumulated distress, right? So the lifetime of experiences that somebody has before they get screened, but before they come in and they're 55 and we click that button in the EHR or Yasir types .10 and then it produces the score, right? So there's 50 years of things that have happened to them. And folks in highly socioeconomically disadvantaged have accrued so many more opportunities for stress, for inflammation, for adverse childhood experiences, for like all of the disruptive things that can dysregulate someone's body and their mind. And I think like that's probably the leading. It's not super specific. Our team actually is working on some biomarkers of that. In fact, I'll give a plug for Kristen, who's giving a seminar tomorrow morning about some immune and hematologic risk markers that can be observed in adolescents in low socioeconomic position neighborhoods in Northeast Ohio. So the idea that these things can initiate like this sort of like immune hematologic inflammatory sort of axis of dysregulation can initiate in childhood in these low socioeconomic position neighborhoods. So that, yeah, so I don't know that we have like a perfect path to causality, Gotham, but I think like the idea that there are distressing circumstances for persons in this neighborhood that accrue over a really long wear period that we're just really bad at measuring in the EHR.
Yeah, it's a really interesting point. And one of the reasons that cardiovascular risk supposedly is lower in Spain and Italy is because of a kind of a siesta, a midday timeout that helps relax people. So who knows what's really at play in some of these neighborhoods as well. Okay, any additional questions or comments? Okay, if not, thanks to both of you. I think that we can move on. So we've used the last session to tie up some loose ends. And the loose ends I'd like to tie up deal with a few questions. The first question, a couple of questions I wanted to throw out to generate some discussion, and we'll go to the more specific ones. And the first question is, as some of you know, I run, I guess I'm still on the faculty of the ECHO program at the University of Chicago, which is pediatric focused on pediatric obesity and cardiovascular risks. And I've been doing that since 2012. And it always comes up that, I'm getting, as a healthcare provider, I'm getting very frustrated with this patient or this family. They've come in several times. I've talked about lifestyle changes with them. I provided a lot of counseling to them. I provided them with referrals, but they don't go. They don't make the changes that I've recommended for them. I've tried shared decision making. I've tried motivational interviewing, and yet the patient comes back and there is no improvement whatsoever. And of course, it applies to anything. Adam was talking about the food bank referrals, and maybe the patient doesn't go. How do you deal with that frustration? Let me throw that out to the group first. What do you do under those circumstances? And I'll give you the strategy that I've recommended to our pediatric colleagues as well as to this group as well. So any suggestions?
One thing that I work on with my students is sometimes we'll get off a call and they feel like it was very unproductive. So I tell them that there's a purpose to every phone call. And sometimes that purpose is just building rapport so that they'll be more open to your suggestion later on. So, and if in that moment you feel like you didn't make a difference or you didn't make any progress, it could be coming, but that moment was part of like leading to that.
Good.
So I try to look at things.
Right. Small steps. Okay. Any others?
Hi. I have actually just had this this conversation yesterday with one of my patients that I actually presented on a case with the last echo round. Right. And I just kind of approached him like, you come to your appointments. I see you're refilling your medications, and he has followed up with referrals, but taking the medications consistently has just been really our main issue. And so I said, well, how could I used your approach. How could I help you, is there something that I can do to help you be more compliant in that space?
Mhm.
And I mean, he just said, no, I just need to do it. And I was like, okay, so, well, that helps me understand that I'm doing what I need to do as your primary care. And so I'll put the ball in your court, and, you know, we'll just continue as is, you know, until, you know, we get to where we got to get to. And, you know, he broke down in tears, and his response of, I don't know why I don't like to take them. I just don't. And
Mhm.
so it at some point it's just a level of acceptance on my behalf as the provider. Like, I'm doing my role. It's just you can't do more than what the patient is willing to
Right.
do. So
Great.
that's
Those are good.
how
Great
I'm using
comments.
to, yeah. So thank you for that scripting, because that really helped me.
Great comments, Amber, and also to Megan. So let me tell you what I recommend. And, you know, there's no scientific study, but this question has come up so often in Echo over the last 12 years that I can, you know, I've just, you know, I've been able to distill how people deal with it. And there's a couple of ways. And one is what Megan was implying, and that is the following, that look, you know, let's set some smaller goals. A lot of folks think, okay, this patient is going to come back, their diabetes is going to be under control, they're going to quit smoking, they're going to have lost weight, they're going to take their medications every night, everything is going to be wonderful in 3 months. That's crazy. That's not going to happen. Let's roll back our expectations to the point, I just want this gentleman or this woman to come back on time for their appointment. That's it, you know. That's all we want to do. And this, you know, Jim and I run a program for adults where we do have higher expectations, but with the kids, all we wanted them to do basically was not to gain weight. You know, that was about it. Okay, not to gain weight in terms of BMI percentile. That would have been a major victory if they'd come back and done that. So that's one approach to it. The other approach that I think Amber is kind of getting at is, what is the situation where I am working very hard, you know, I had multiple visits, we've done lots of counseling, and something is not working. What I don't recommend is going and saying, well, let's try to maybe simplify his regimen for his medications, or maybe we'll send him to Karen Bailey and he'll get more diabetes education, even though he's seen them already. Or maybe I will do something else, or maybe he's got a transportation issue. We'll give him vouchers to come and maybe that'll help him. Or maybe I'll call his employer or give him a note saying that he's got to take his medication at a certain time. I don't think that's going to work. As Amber was implying, I have done what I can. This is the script, I think. You know, I've noticed that you do have this condition. Your diabetes is not under control. I have done what I can for you to help you. And I've worked very hard at that. And I want to tell you that maybe it is okay for us to take a little break from this effort for now, which will give us both a chance to rethink what we want to do in the future. And you have to make it absolutely clear, I'm not abandoning you or your condition or anything of that sort. Maybe you can come in next time and we'll talk about your ankle or talk about something else that's not related to what's going on right now, because I think that might be the best approach. And for kids, what we often say is, I don't think your son or daughter is quite ready to make the lifestyle changes that, you know, he or she needs to make. And I think that you're struggling as a family. Why don't you come back and see me when you feel you are ready? And believe it or not, in many instances, that is a motivator for people. Not that they feel that you're abandoning them, but that they suddenly feel this sense of response. Wait a second, you know, Amber's been working very hard for me, and I just, you know, all I have to do is set an alarm at noon to take my medicine. Maybe I should try doing that. And that's a real, you know, that's the approach I take. But any other suggestions from anyone?
Because I'll just maybe not so much of a suggestion, but Amber, when you were talking, it reminded me a little bit. What Yasir and I had a slide or two in there from Victor Montori at Mayo Clinic, and he has this approach aligned to the statin choice tool, also to some of his work on diabetes medication adherence and lifestyle change. He's got a website for it. I think it's like minimallydisruptive.org. And he's really, he was really enamored with this, you know, so Victor had a chance to study one of my original fields, which is medical anthropology, for quite a while. And there's a big literature on the biographic disruption that happens when you're diagnosed with a disease or told that you need to take another medicine. And the idea here is that, like, in order to successfully make those changes in your life, you need to accept that your biography has now changed. You're now a person with disease in your life. You're now a person who has to take medicine on a regular basis. And for men, oftentimes, especially, like, it can be very, very challenging to be accepting of that biographic change. And sometimes it's much easier to just reject it and not do it. I know this resonates with me. Like, I did not want to take my GERD medicine when they told me that I had GERD, but, like, man, it really makes me feel better. But the trick there is, especially when the medicine or the med routine is not tied to the experience of feeling better, it becomes especially harder, because then you're just sort of taking it on trust and belief in the care system and in, you know, all of this evidence that doctors understand, but you may have only a peripheral understanding of. And so, like, you have no, like, personal tactile knowledge that is an improvement in your life. And instead, it just feels like a disruption to your life, which is not a good feeling, right? For a lot of people who have to take medicine. And then the more medicines that you have, the more disruptive it is, right? So, and the idea isn't necessarily to remove medicines, but one of the first things that Victor recommends is just to make sure that we're acknowledging, and sometimes just being open with folks, that, look, yeah, we know, like, this is a shift in your life, right? Like, how can I help you with this shift in your life? That, yeah, you do have these conditions, and the reason I'm asking you to do this is not because, like, I know that it doesn't feel bad when you don't take your medicine, you don't feel worse, but what I want is to avoid these sort of longer term consequences. And it's really hard, right? The behavioral economics of this is hard with anything, right? Like, it's a future, right? It's a future loss that we're avoiding. And human beings, just in general, are very poor at avoiding future losses. We're much better at near-term stuff. So all of that is happening in that, you know, all of that, like, social psychology is wrapped up in that little tiny moment. So I think all the suggestions are really good, but I do think, like, just maybe the one point that I'm making here is just remembering that, like, people do have to integrate, you know, taking that one more medicine or having that new diagnosis on their problem list into their personal biography, and that becomes a part of their life, and making sure that, you know, to the extent that you know, checking in with them and seeing, like, is that a struggle for them? Is there more that they want to talk about that?
Yeah, that's really great. Once you're taking medicine, we avoid labels. And I know Liz Beverly's reminded us not to call ourselves hypertensive or diabetic, but then you've got that identity. And that's not comfortable for a lot of patients, for sure. Melissa, I see your hand is raised. Do you have a comment?
I do. Can you hear me?
Yes, go ahead.
Yeah, actually, fascinating conversation today. I just wanted to share a perspective. I know this is preliminary data, but we're getting ready to publish a data set of 475 Amish Mennonite and women whom we interviewed at clinics throughout the state of Ohio. And what was really interesting is that we asked them about their self-identified health issues. I believe this is the largest study and data set that's been recorded to date. And we also asked them about how they rated their health, that typical scale from 1 to 5, from poor to excellent. What we thought was interesting is that individuals who reported having high blood pressure or high cholesterol were more likely to report that they had better health. And we thought about that as a team, and I'm bringing this up from this perspective, is that, you know, when we look at medications, truly those are absolutely two health issues that can be readily controlled, right, by medication. And I feel like there's been this positive outcome that even though they've been diagnosed with these two issues of high cholesterol or high blood pressure, the medication itself, there's been a positive effect, right? They've seen the impact, and therefore they've rated their health higher than those who did not report those issues. So I think, again, we are humans who love reward, and I know diabetes just doesn't have clearly that trajectory of, you know, positive impact at all times, but it does appear, at least from our research, that those who are seeing an impact of the medication and how it can help them may in fact change perceptions of how their health really is.
Yeah, that's fascinating. Thanks for sharing that. I want to move on to another question because we have several more and that I thought of, and then this has emerged through almost, I'd say, at least half the case studies that that we've discussed in this series. And I'll give you my thoughts to begin with, and we can throw it open. Is that how do you engage family members, spouses, partners, children, parents, siblings, friends in the care or the self-care of the individual patient? Now, this is a challenging thing. And I'll give you some tips on some of the tricks I have done. I mean, I have lots of couples who are patients, and usually they come by themselves. And for example, it might be a husband who's there and he's got type 2 diabetes. It's out of control, but he's married and has someone at home that's not available. And I think that I will often speak to the patient's spouse or partner on the phone while they're in the clinic so that we have a mutual understanding. And that does two things. First of all, you have another person who understands what the plan is. But also, I think when the spouse hears the doctor's voice saying, hey, this guy is calling me and telling me that this is what he would like my husband to, what he recommends for my husband, or that really has quite a bit of impact on them, and say, well, it must be pretty substantial. It must be pretty important. And he must take my opinion or my input into this quite seriously. Of course, you need the permission of the patients to do this, but usually they're able to identify someone who's able to help out. And not everybody, not all of our patients have a young, highly educated child who can come with them to the appointments and take care of things. So finding that extra person is important. Kurt Stange and his colleague, Rebecca Etz, who Kurt is in my department here at Case, developed a primary care quality measure that's now been adopted by the National Quality Forum, which I'm part of, and basically it's a CMS quality measure. And one of the questions on it is, does your doctor know the most important people in your life? And I think it's a really important question to ask. And I've been asking it now for a couple of years. Sad thing is some people really don't have anybody that's really important. And to see, an older person in that situation during the COVID pandemic is really heartbreaking, but it does happen quite often. But when they do, and you'd be surprised at who it is, it might not be a child. Some people are estranged from their children. It might be their neighbor. It might be a sister, a sibling, or someone else. But knowing that person and engaging them actively is kind of the approach I would recommend. Nathaniel, did you have a comment? You're muted.
Yes, sir. So I generally kind of set the tone or the perspective that, hey, the reasons why humans are so successful, in the time that we've been here is basically because we have communities, you know what I mean? And that basically we are so much stronger together than we are as single individuals. And it's especially apparent in the elderly populations that, say, for example, the people who thrive, kind of looking at blue zones, they have rich communities. They exercise together, they eat together, they, socialize together. And that basically being devoid of that limits your life expectancy and worsens your health outcomes. And so, generally, sometimes people respond well to that, sometimes they don't, but at least it plants a seed.
Yeah, it's a really interesting point. There was a study that I just heard about on NPR about London, England, where Kensington or Earl's Court, which are the richest neighborhoods in London, the average man lives to be 93 years old. It's pretty amazing. And I think it's just a few kilometers away. It's in the 60s. So it's which we see that phenomenon in many, many places. But that was one of the things they pointed out, that these are men living to be 93, that they have networks and social organizations and lawn bowling and all of these things that they do in their old age, which certainly does have an effect. But that's a great suggestion. So I think what you're suggesting is, by letting the patient know, hey, if you're part of somebody else, you're going to find it easier to manage your illness and you're going to live a longer life. Good advice. Any additional comments about that?
I just take your strategy even one step further, almost to the verge of ridiculousness, where I call them and say, hey, I need you at the next appointment. And at that next appointment, like Adam said, integrating a biography, I bestow upon them with the authority invested in the white coat, hands on their shoulders, eyes to eyes. you are now in charge of his diet and I need you to whatever. And I can't tell you what a transformational superpower they suddenly get as soon as you bestow upon them that title or whatever.
No, and I've been just as ridiculous. I've gone out to the waiting room and grabbed Mrs. or Mr. whoever it is and said, I need you to come back here for a few minutes. I need to speak to you. And they go, me? Yes, you. And it works. I mean, Austin's right. It does have an impact. Okay. So I wanted to turn to some of the other questions. Now, these were raised by the group over the course of the series as sort of loose ends, and I hope that we can answer them. One is, and I don't think Kathleen Dungan's on, but Karen is on. First question is, how would you initially manage the patient with type 1 diabetes? We've had some really interesting cases. My approach is really simplistic and probably out of date. I follow something called the Texas protocol, which is single dose, long-acting insulin at night, Basaglar, Olantus, and then start adjusting based on what we find. That's it. Karen, what would you recommend?
Well, I mean, as a diabetes educator, we kind of focus on the survival skills when you first get someone with type 1 after taking insulin. So, I would make sure that they know how to take insulin, ask them, what kind are you taking? How do you take it? How is it stored? And then talk about that risk of hypoglycemia. Have you ever felt that way? And how to treat it. So that the first sessions usually are around medicine taking and survival skills with diabetes.
Yeah, I think that, I think referral to a certified diabetes educator is pretty much obligatory for the new patient with type 1 diabetes, regardless of their age. So, and my traditional training has said, get their sugar under control and then ask questions later, etc. So rehydrate them if that's necessary. Start them on that once nightly insulin. I think the recommended dose is 0.4 to 0.6 units per kilogram of body weight. Get them in with a diabetes educator almost as soon as possible, because they're going to have to do this on their own. And if they don't, they'll get into big trouble. So that's the extent of it. Now, is this type 1? Is this type 2? Do they have high cholesterol? Do they need to quit smoking? All of those things, I think you will do, of course we'll do, but those are the initial priorities that I would look at. The other questions deal with stress and its impact on diabetes. I don't have a lot of expertise. I would imagine that patients who are stressed have distractions that are taking them away from self-care, but the actual stress itself, I'm not familiar with. If anyone has any comments about that, I'd appreciate it as a sort of etiological factor in type 2 diabetes or type 1 diabetes. And the final question, I think, is going to be hard without Kathleen here, is the role of alcohol in causing diabetes or exacerbating it. Certainly will exacerbate it through poor nutrition and self-care. I think that would be the main thing that I would be concerned with in terms of diabetes control. The idea that you're somehow using up your pancreas, I think, is probably less likely. But poor nutrition, self-care, obesity associated with excessive alcohol intake, all will exacerbate type 2 diabetes. That's the best answer I could find to that question. So now that we have addressed some of those, are there any additional loose ends that you think we ought to address in the last few minutes here? Let me scroll through.
I have a question. So
Sure.
There's been some instances where I have a clinical pharmacist here at the practice I work at. And granted, as kind of a preface, I've worked at a federally qualified health clinic for a couple of years before my current position. And I've learned that sometimes it might be better to actually have patients, use regimens that's more easy for them that's, you know, kind of tied to ease of use as opposed to like clinical outcomes. So say, for example, like using NPH insulin or 70/30 in certain, you know, patients who don't want to do multiple injections per day. And granted, you know, it comes at a cost. Like say, for example, you're not going to probably get that great of glycemic control as in like, say, for example, a multiple injection insulin with both long acting and short acting. But, you know, hey, if you can get their A1C down a couple of points, it might be worth it despite, you know, not being able to do as well as you could theoretically with another agent. And I think it kind of relates back to, again, just setting the smart goals that you discussed before that, you know, hey, sometimes improved is better than nothing, you know? So.
Yeah, no, that's an excellent point. I mean, the best medicine is the one that the patient is actually taking, right? I mean, regimens can get very complicated. And, you know, I've referred lots of patients to certified diabetes educators. Some of our patients, unfortunately, just cannot follow through on complicated regimens. Sliding scales, for example, which of course have gone out of favor. So a simpler regimen is better. And, you know, I think there's nothing wrong with moving stepwise and saying, if we're starting you on once nightly insulin, then we'll start at the short acting a little later. Once you have mastered this, we'll make things a little bit easier for you as you go along as well. Okay. Thank you, Nate. Any additional questions or comments?
This is just a dumb one, but these GLP-1 agonists, do you leave them on them forever and ever and ever? Do you try and wean them down? Do you just stop them cold turkey one day? I mean, I now I've gotten them and it's kind of like, what do you do after they've been successful for years? That's
$1 million question that I am struggling with because I prescribe a lot of them. They are very expensive, as you've probably gone through the prior auth process and all that with those things. What limited evidence is available shows that if you stop them, patients will regain weight. Or if they're being used for diabetes, their diabetes will be exacerbated. I don't know how many of you read The Economist magazine, but there was a feature a couple of weeks ago about obesity and the GLP-1 agonists and how people will eat what they want and then inject and then eat and inject. And this process will go on for years all over the world. Well, that I don't think is going to happen. First of all, I have already seen in 100, 150 patients I prescribed the GLP-1 agonist for, mostly for obesity, some sort of an attenuation that takes place even when patients are taking the medication. So they may be on 3 milligrams per day of Saxenda, which is the highest dose, and they may have lost a lot of weight, but then they start to regain weight, and they are, it's unexplainable for them. And when you really think about how these medications work, the primary mechanism is delayed gastric emptying. And if you eat too much, of course, you're going to throw up. But people can get accustomed to that feeling and they can overeat. And, and even though they might have a little nausea, that might fade over time. And they might start to regain weight, as patients often do after bariatric surgery. So I still will stick with the same principle I've used for 20 plus years, is I don't want to put anybody on an obesity medication for more than a year, because I don't believe we are at the point yet where anything can be used for life to control weight. I think that you have to prime the patient with lifestyle changes, gradually wean them off and say, okay, this is all you now. This is not the Wegovy or the Ozempic or whatever it happens to be, because first of all, it's just way too expensive, and it's probably not going to work in the long term. But great question. I guess we'll have to wait and see what happens over the next couple of years or so. All right. Well, thanks everyone. I've had a wonderful time this series. This fall, we're going to focus on a series that focuses on some of the things actually Adam and Yasir talked about, more environmental factors, social determinants of health. And of course, building that around case studies, which incorporate those aspects into our series as well. So I hope you've had a good time, and we will send it back to Claire for a moment.
Sure. And I'll just comment, I was looking at our deliverables because Cardio puts out a lot of best practice resources about alcohol use because it was so familiar, but there's a podcast coming out hopefully in May. So keep an eye out for that. But I knew we had something in the pipeline. Anyway. So a post-clinic survey has been emailed to you about today's talk. Please take a moment to fill that out to give us feedback. And then there's an exit survey that should be sent to you in 2 minutes. This one's a little bit longer. It mirrors the pre-survey that you did back in January, December, January. We do ask that you fill this out, and you will keep getting reminders to fill this out if you don't do so. So please do it. It gives us feedback for our data and evaluation team on cardio in general, echo in general, and how this clinic went. Do it at your convenience, but by April 28th at the latest. CME credits. So you do get CME credits for participating. We partner with MetroHealth to do the CME. So you will get an email. My guess would be early next week from myevaluations.com. So the amount of CME will depend on how many clinics that you attended. So I send my contact at Metro the attendance, and she fills out on her end. If you don't get that email by like this time next week, send me an email and I'll try and figure out what's going on. But you have until May 5th to fill out that if you want to claim the CME credit. And then, as Gotham said, the fall echo clinic, it is actually officially open. So we are accepting registrations. If you go to our website, we welcome repeat people if you want to do it again, or if you want to send the information on to your colleagues, we would appreciate that. If you have any questions, let me know. Feel free to email me at any time.
Thank you, Claire. Thanks, everyone. Have a wonderful spring, and hopefully we'll see you in the fall. Take care.